So we should do the last lectures, and then we're going to give you a quick review session. I'm just going to go over the past lectures and the things that you guys need to pay attention to. Okay. Okay. You guys see the thingy?
Yes.
Yes, doctor, we see it.
Okay. What does it say? Because they have opened a lot of things.
This is the sports
Sports
medicine
medicine 5-6.
5 and 6.
Okay, so let's just go through that. So good afternoon, everyone. So we're gonna we're gonna do the last two lectures of this block. So again, the approach to MSK disorders, we already did that before. So we're just gonna talk about it briefly, and then I'm gonna talk about deformities in the musculoskeletal system and how we usually approach that. Okay, so in musculoskeletal system, usually this is we talked about them many times, like etiologies in general. These are the main things that we did the exercise with each other over the past 2 months. If somebody comes to you with a pain or with a swelling or with a musculoskeletal problem, you need to ask a few questions in the history, and then you tailor it down to what is the general etiology. And then you have your set of questions for each one. Either it's a trauma, infection, inflammatory, neoplastic, degenerative, metabolic. These are the main etiologies that you need to ask questions. Trauma, you will ask the patient, did you fall down? Did something happen? Yeah, I fell down 2 days ago. So it's the acuity and the mechanism of injury. That's very important. Infectious. Something has been gradually happening. Patient has risk factors for that, and then signs of infection, swelling, fever, discharge, stuff like that. Inflammatory arthritis, they should come with a systematic type of problem most of the time. So you'd ask about skin rashes, migratory type of joint pain, and things that can narrow it down to such an inflammatory process. Neoplastic, and the question related to neoplastic case, weight loss, swelling with gradual increase in size, and the location of the swelling and stuff like that. And then degenerative aging population with joint pain, limitation of movement that's gradually worsening in terms of function and pain as well. And then metabolic, vitamin D deficiency or any type of bone mineral disease, whether in children or in adults, that can present itself, osteoporosis, vitamin D deficiency, and rickets type of disease and stuff like that. So again, I think you guys saw this image a lot of time. So it's very important to understand that if you have somebody with a fracture and then an open wound at the same level, you need to think of an open fracture. This is something very, very important for you guys to understand. And the most important thing for open fractures is what, guys? You can see it, it's written down there. It's the antibiotic administration. So the patient needs to receive antibiotics as soon as possible because this has a huge correlation with the outcome of their injury and the impact on prognosis. And then again, we talk about fractures and dislocations or both that can happen. We already did that. I'm not going to talk into much details about it, but this is general trauma, either in a joint or in a bone that's not around the joint. And it can be a fracture, it can be a dislocation, or it can be at the joint with a fracture, which is a fracture dislocation. Okay, and then usually the approach in general, we do the history. You ask about pain. Is it a cosmetic problem? This is something sometimes you see it in scoliosis, for example, people with back pain, and then you ask, well, okay, does it cause pain? We don't ask about cosmetic all the time, but it's main thing is pain and limited function, and then this is the mode of onset for the pain usually, like acute, insidious, and then self-limited, chronic, and then any joint affected. This you see it more of the inflammatory type of thing, and then you do physical examination. You see deformity. You see any tender point or palpate any tender point in a limited function with the exam range of motion, and then you investigate with full length of the limbs affected, and then go on. So, guys, from this slide, we're transitioning now to the deformities part of this lecture. So the approach to Minsky, you guys all know it, and now we are approaching the deformity stuff. So I'm gonna go over the same approach now. Some things will make sense more of that, because when somebody comes to you now with a deformity problem, they're not gonna tell you most of the time it's pain. They will have pain, but most of the time, at the same time, they will have cosmetic problems. Okay, length longer than the other or shorter than the other, scoliosis, some deformity in the shoulders, and stuff like that can have problem. It can have pain, can have limited function. So, and then you examine the deformity as well. And then you do investigation, x-rays. Always ask for full length to see the whole bone, so you can know where the deformity arising from. Okay, and then going now more into deformity. Okay, so you need to check what are you investigating, and the patient's complain. So they complain of knee pain, some deformity around the knee. So you need to take a full length from the hip to the ankle to see. So adult limb deformity, the definition, it's a condition that results from childhood growth impairment, metabolic bone disorder, or severe osteoarthritis, or trauma, or fracture, malunion, non-union. Anything that can affect the alignment of the long bone. That, as you can see on the image, A and B. So A is the deformity. You can see the line doesn't pass around the center of the knee. However, in B, after they did the osteotomy and corrected the alignment, the line passes around the center of the knee. So if the line is around the lateral aspect, not as in the center, there will be more loading on the lateral aspect of the knee. So they will have a valgus deformity from a chronic wear of the lateral compartment. And then we just try to bring that center of gravity to the middle. Okay, so how do we make the diagnosis? We make it with a combination of clinical exam and plain full length. So this patient, for example, will come with a knee pain. When you examine them, they will have a laterally placed knee pain. You do a full length X-ray, and then you see the center of gravity passes laterally. So you know there's more loading on the lateral aspect. You do an MRI, you can see more wear in their meniscus. And then usually we approach that with corrective osteotomy. So we correct that. We have a lot of measurement to do that, but this is what the approach for deformity occur. Again, deformity can also happen around the spine as well. Okay, so spinal deformity, idiopathic coordinative condition of adult spine. You can see it in the coronal plane or in the sagittal plane. So how do we do the diagnosis? Other than history and physical examination, we do full length of a spine radiographs. And then once we reach the diagnosis, then we see what is the problem. Is it cosmesis? Is it pain? Is it functional problem? And then we treat that. So we treat it with non-operative management and say the physical therapy. If it doesn't work, then we do intervention with surgery, depending on the deformity correction plan and what kind of pain and non-operative management that failed for us to move forward. So you can see here, this is a leg length discrepancy on the left. And you see here, we try to put some blocks on the right leg and books. And then you see the pelvis is not way tilted. So this is, we know that the limb now is kind of neutralized. And then with the pelvis not tilted, then I know that both limbs now are in line. Okay, however, the right side, we know it's short. As you can see, just from looking at it, you do the proper measurement. You see the most of the shortening is happening from the femur on the right side. And then we approach that accordingly. On the other image on the right, for example, you can see that it's not more of a leg length discrepancy. However, you can see the right knee, there's a deformity of the distal femur and corresponding deformity of the proximal tibia. If you do your angulation, you would know where exactly the deformity, and then you correct that. The center of gravity, if you draw it down, it's way lateral. So there is more lateral wear than the middle part or the medial part. And this is how you diagnose these stuff after the history physical, you do the x-rays. Okay. So this is the introduction of some of the devices that we do. So just back to this image. Okay. Do we have another image of that? Okay, yeah. So these are type of deformity. So you have this coronal deformity either in length or in varus or valgus malalignment. Sometimes you can have it in sagittal plane or lateral plane, fixed flexion or procurvatum or recurvatum that happens around the knee, which is like an apex posterior, apex anterior. The important thing that we try to treat these things non-op if it's non-op, but for example, this is very short. So the only solution for this is we have to do some lengthening. Okay, and sometimes with this, sometimes we have to do corrective sterotomy. Sometimes we can do it acutely, you correct it, and then that's it. Or we have to put a device and do it gradually over time. Okay, like this device. Okay, so we have like this is a TSF or like a Taylor spatula frame, which is a circular external fixator that goes around the bone, normal, for example, and then put pins in the bone and then down there and then correct the deformity in between. And then we play with the planes. You can play with the coronal plane, sagittal plane, and also the axial plane. Okay, and then it's a lot of it's complex and it needs a lot of thinking and a lot of readings and a lot of measurements. However, the take-home message from this, it's a device applied externally that can correct the deformity gradually. So you can see here, this is what I was talking about when you have some people with people with some malalignment. Sorry, I'm trying to get to chat because people are asking questions. How does putting nails in the femur corrects the deformity? I didn't say anything about putting nail in the femur to correct, for example, a coronal deformity, valgus, varus. However, they use sometimes nails to correct lengthening. They have a nail, they put it in the femur, and then they start to lengthen. Okay? Another question somebody's asking, how the deformity to the lateral? Is it not medial deformity regarding X-ray image? Which image you're talking about? Child with a book. So this child with a book is something, and this deformity is something else. They're not the same patient. This is a patient, and this is a different patient. Which picture you took? Okay, so I need to answer one question. Okay, so the person asking about the medial, the deformity is to the lateral. So this deformity, there is apex medial. However, the center of gravity is passing lateral, but it's apex medial. You understand that? So the deformity is causing the valgus knee, apex medial, which makes it a valgus knee. The knee is going outward. But the center of gravity, if you draw a line from the center of the femoral head to the ankle, it goes lateral. You get it? But if you look at the image, you think like they should be loading the medial part. But it's not about that. The center of gravity, there's axial load that goes through that line, that's lateral. So there's more wear on the lateral part. But this is a little bit of a deformity of the distal femur. Okay, so how does putting a nail in the femur corrects the deformity? The first picture of the deformity, not the foot image. The picture with malalignment of the femur for the left leg, and they put nails and correct the center of gravity. Okay, so you're talking about this one, right? The one on the right? So this is not a nail, this is a plate. So yes, we can correct a coronal deformity with the plate. They broke the bone, they break the bone, okay, put it in the alignment they want, and they just put a plate. So it's not putting a nail, it's just putting a plate and screws. You can't correct coronal deformity with plate and screws. Okay? All right, okay. So moving forward, no worries. Okay, so moving forward, okay, so again, it's same application of what we talked about. So coronal deformity, we do this alignment. You don't need to know all this, but at least to understand there's a problem with the knee center of gravity, and then you follow what the problem is, and then you track that. What do you mean by coronal and sagittal fixation? I'm talking about coronal and sagittal malalignment, and then we correct that based on our degrees or our alignment. So guys, it's a little bit very advanced for you, but for example, look at this image. Okay, so we have some alignment and angles around the distal femur and proximal tibia and the ankle and also the femur. We follow these numbers. So when we draw a line, this line should pass. This is just an example of the lower extremity. There is a line in the upper extremity, there's a line in the forearm and everything else, and the distal radius, and we follow that. But coronal, I mean, when I'm looking at the front, okay, there is anything that going outward or inward, this is coronal malalignment. I fix that back to the normal alignment. Normal alignment, we have a reference. For every bone, we have a reference. So we do that. We do the corrective osteotomy, we break the bone, we bring it to that alignment. For the sagittal, you're looking from the side. And then we have some degrees, we follow that. We have some references, and then we fix it accordingly. So when you look from the side, you see the alignment. And when you look from the front, you see the alignment. This is something very specialized for the deformity limb surgeons, but we have references that we follow, and then we need to understand if there is a malalignment problem. So again, going through these things, it's just showing you pictures of what I was talking about when you put this, when you put like a circular device, just to correct the deformity. I'm not going to ask you major questions about this, so don't worry about it. It's just, for example, this image here, you can see there's a fixation that's failing. And when it's failing, we need to understand why it's failing and where it's going to fail. So this is, you can see there's a tilt here. This is a coronal problem. You're looking from the front, it is tilting outward. So apex, it's tilting outward. So because this is lateral, this is medial. Okay, so this is the apex. So apex lateral. And then when you look at the lateral view, you look at apex anterior. You don't need to understand this because sometimes we need a lot of x-rays to understand what is it. But I'm just telling you now, there's a deformity. You can see it in the coronal plane and the sagittal plane. So for us, we fix it usually with some type of circular frame that we try to correct these both deformities gradually, and then we align it. Like for example, here and here, you can see that, okay? So usually when we put a circular frame, what are the most common complications that happens from these type of devices? Because it's commonly used. It can be commonly used.
Infections?
Yes. Pin site infection, it can happen. It's the most common one. So pin site infection can happen. That's why they have periodic visits to the doctor, and then we see that accordingly. How do we, just before this slide, sorry. Just before this slide, sorry. So they can have infection, they can have pain, okay, and they can have failure of correction of the deformity, okay, but the most common thing is infection. And how you identify that? Sometimes you can see some pus coming out or redness or a pain from the patient. Okay, last thing about this lecture is the deformity that happens in kids. So sometimes they will have a growth abnormality, most likely due to a trauma. So this picture, if you look with me here, this is a picture where the growth plate is here. So sometimes the growth plate has to have a symmetric growth, medial and lateral. So the bone can be lengthened symmetrically. Sometimes you can have a trauma to the medial part or the lateral part. And then it can grow out away from the other part. And it can go into valgus and varus. Okay? Sometimes we do guided growth. We lock it in order for us to allow the other side to open up or to match it. It's just guided growth to correct the deformity. Same thing that I showed you before. Sometimes we need to do the fixation because it's an adult patient. With adult patients, they cannot grow more. So we have to correct it on the spot. However, when you have the same deformity that I showed you in adults and kids, we can do guided growth. You can stop one side to let the knee grow out of a valgus, for example, and vice versa. This is called like a growth arrest type of or guided growth type of surgery. Okay. طيب somebody really excited what to focus on the lecture for exam. I'm going to give you the review session. Don't worry about it, guys. Let me finish this and they'll give it to you. Okay. So how do we usually manage people, especially in kids, when they have problems with growth? We do non-operative measures, whether with orthotics, for example, the kid with leg discrepancy, not the one I just showed you in the pictures. However, somebody with minimal, like 1 centimeter or 2 centimeter, we can give them orthotics or some shoe fillers that can match the length of the other side, and it can help with that. Okay, if it doesn't work, then we do guided growth, as I just mentioned. So this is just in general. Guys, don't worry about it. I'm not going to ask you crazy stuff and crazy question out of this, okay? So this is the end of the deformity and sports thing. Let's start a review session, okay? Okay. Lecture is so vague. Deformity or sagittal deformity, and then there are ways to correct that deformity. That's it. I'm not going to ask you to put a frame on this, how to correct this from valgus to varus, nothing crazy like that. It's just there are deformity that can happen in the musculoskeletal system from whatever etiology that can happen. Okay, okay. Let's start with the LGDs, guys. With the review session. There. Okay, do you guys see any lecture? Do you see anything or no?
No.
Sorry?
No, we don't see anything now.
Okay. Okay. Sure. Okay, guys. So let's start from the last lecture and then go down, okay? So, for example, in deformities, usually, the things I'm gonna ask about usually is, for example, coronal deformities. You need to understand what I mean by coronal deformities. You know what I mean by that? Sagittal deformities, coronal deformities, axial deformities. It's very easy. When you look at the X-ray from the front, if there's a deformity that's going to be very clear, then you know it's a coronal plane deformity. And usually they can have varus and valgus, whether in the arms or on the legs. You get that? If they have an apex anterior deformity of the leg or the femur, you know that it's sagittal plane deformity. If the whole thing is rotated, then you know it's an axial plane deformity or rotational deformity. So these are the most important thing in this lecture. You get it, guys? I just need to understand what type of deformity that you're going to see. I'm not going to give you something with a center of a gravity a little bit to the lateral and say, is this correct or no? No, it's just need to understand what type of deformity you see. You see something from the front, you see something from the side. You know that I'm dealing with a coronal plane or maybe a sagittal plane deformity. That's it. The other thing is the type of fixation that we do usually. That you need just we put a device from on the leg or on the arm from outside, and it can guide the growth or can at least help with the deformity gradually. And it has complications, and the common complication is infection. And this is just something very important you need to understand. And usually how to approach people with deformities, like exactly what I just mentioned in the history and physical examination. And usually pediatric group, they are more prone to deformities because of the growth plate. So understanding the growth plate injuries are very important. Okay?
Okay, doctor.
So these are the take-home message. And then, okay, let's go back from the lectures and then slowly yada, yada, yada. Okay, there. For the approach, again, guys, just focus on the etiologies. I'm going to give you some time questions about the patient with whatever type of disease that's sending signals about what type of past medical they have, and then you just need to know the etiology and the things I just explained to you guys. And then people with injuries and people with whatever acute management they have. For example, somebody with an open fracture, what I just told you, they need antibiotics. Somebody with inflammatory arthritis, they just need to manage their pain. Somebody with a neoplasm, you need to understand that and then refer to the appropriate service and so on, like that. And then it's very important to focus on history and physical examination, any approach to anything. Okay?
Okay.
And then
Doctor, we can't see your screen at the moment.
you can?
Can't. If you're sharing anything, we can't see it.
Okay, yeah, I'm not sharing anything.
Oh, okay, tamam.
Okay, so guys, I don't have a lot of time, but anyways, I'm gonna go through the review as I promised. Okay, so what I mean by apex deformity, do you see my cursor?
No, we can't see anything.
No, doc. Nothing.
Okay, I need something where I can draw.
Whiteboard?
Yeah, sure.
Yeah, share with.
Yeah, sure. Okay, one sec. Okay, so you see my Word document? You guys see?
Yes,
Yeah, we can see it now.
Yes.
Okay, so for example, this is the tibia, and this is forming the ankle down there, okay? You get it, guys? I'm
Yes.
looking at the front, صح? And now this is the tibia, for example, and I'm looking from the side. Anyways, this is how it's shaped like that sometimes, okay? From the side. So this is anterior, this is posterior, okay? This is medial, and this is lateral, okay? This is coronal view, صح? And this is lateral. When I say apex deformity, for example, this is anterior. If this image, for example, is like this, can I do? No, I can't. I'll draw it again. Okay, but if this thing becomes like that, this is apex anterior. You get it?
This is not a fracture?
It's a fracture, but I'm just explaining the deformity on the lateral plane. It's the same thing. If you want me to draw it like this, look. It's the same bone that I just showed you just now, and it's apex anterior. This is the deformity. It's very clear. If it happened the other side, apex posterior, toward the side. If it's here, it's apex medial, which goes with
None.
valgus. When the apex is lateral, goes with varus. Okay, guys? Does this explain it?
Yes, doc.
Right. Let's keep this. Maybe it's going to be helpful. I need next page. Okay, I can't. Anyways, it's okay. So I'll just do this. Right. More questions, guys, right? Right, okay. So, guys, don't write in this because I cannot focus. I might miss stuff. So just ask me, or guys talk to each other and then ask me. Is it because the apex is moving anteriorly while the other part is moving posteriorly? No, this is translation. We're talking about the deformity, where the apex of the deformity is going. That's it. What is the difference between coronal deformity and valgus? It's the same. It just, you can say either. If you tell me somebody with a knee going more in valgus, I know that you're talking the apex medial, and vice versa. Okay, somebody's helping me with the insert a new page. I feel like old, but it's okay. Thank you. Right. Do you guys see anything now or no? Or just the Word document?
The Word document.
Okay. Like, let me just stop sharing. Okay. And then usually in the sport medicine lectures, you guys need to focus on the tendon injuries and the anatomical structure. I explained in the lectures. Everything is mentioned in the lectures. So you need to focus on the wrist joint, elbow joint, ankle joint, the DRUJ, the PRUJ, the ankle syndesmosis, and the ligaments that is around the knee. These are things that you need to focus on. It's just anatomy that it's already mentioned in the lecture. I think that the joint and ligament lecture has a lot of information in it. And then you need to know exactly what are the joints and what are they made of. Are they hinge joint? Is it pivot joint? And the stuff it's also mentioned in the lecture. You need to know that and the example of each joint. And then the approach for anybody with a wrist, elbow, shoulder injury, what type of view you need sometimes. Somebody, if I say there is dorsal dislocation of a bone, you need to see a lateral X-ray, not an AP X-ray, because you need to see the dorsal part, because this is the lateral view, dorsal, posterior and anterior, and same thing if I want to see something on the coronal plane. And then in the trauma, you remember when we talked about the lower extremity fractures, that the most important things about lower extremity fracture is the ambulatory status and how they walk and how they usually need to get out of bed and focus on the pain part and the recovery part. This is very important, the lower extremity. So this is something very, very important. As for the upper limb trauma, you need to know the difference between high energy and low energy. I explained this on a few occasions, that you need to know, like, for example, gunshot wound, falling from height more than 1 meter or 2 meters. This is a high energy trauma. Somebody who fell from the bed, this is low energy trauma. And then you need to understand this type of thing. And the intra-articular fractures, extra-articular fractures, or extra-articular pain and stuff like that. You just need to understand what's happening. There is nothing crazy in terms of question, but just you need to know everything that we discussed and I showed you in the lecture is there, but nothing out of proportion. In the muscular dystrophy, you guys have a full lecture with a lot of information around it. So it's any questions going to be from the lectures. So just read the lectures and make sure that you guys understand that. Same thing for the neuromuscular injuries, guys. Okay, you need to know the anatomy, you need to know the approach, history, physical, and the type of investigations we do with that type of thing. This is very important. And the first 3 lectures, where there's a lot more pictures, less than talking, it's very easy, guys. You need to focus on again, I always focus on the history and physical examination, and usually the etiologies that we talked about, whether inflammatory arthritis, how do you approach that? Somebody with osteoporosis, how do we approach that? And stuff like that. It's very important to know. So usually I mentioned a question about somebody who's 50. They have, for example, knee pain. It's been gradual. They cannot walk more than 1 block, and they have a lot of past medical. You know, it's degenerative. There's something alarming in the question that it's degenerative. I need to know, especially with arthralgia, intra-articular versus extra-articular anatomical structure that can cause pain. This is something very important you need to understand, guys. It's also mentioned in the arthralgia lectures and also mentioned in the joint and ligaments injury. So there's a lot of informations here and there, okay? As for the bone pain, you guys need to focus again on the etiologies. We talked about it a lot, and the how to approach people with bone pain. It's very simple and very straightforward, okay? Same thing with the fractures. You just need some time to understand the fracture morphology, okay? Nothing crazy. It's just the things that we talked about. The significant soft tissue damage usually happens where, and the simple fracture, what kind of thing associated with that. Things are very clear. You can see it even from the images, nothing crazy about that. So this is usually the most common things that you guys gonna have. Which specific movement what? Can rupture, and which ligament or muscle? This is very vague or very general. So it depends on the joint involved. So know the structure around the joint, you will know what type of ligament or what type of muscle usually injured. And they are very common. So shoulder, rotator cuff, elbow, biceps, wrist, extensor tendons or flexor tendons. Hip, you have the iliopsoas, usually not ruptured, but it's always can cause pain. Knee, you have the lateral ligament and the medial ligament, the MCL and LCL, and you have the quadriceps and patellar tendons that can be ruptured. Ankle, you can have the deltoid ligaments or the medial or lateral ligaments, usually something like that, but nothing is crazy. Okay, guys, I came to the end of my review.
Okay.
Any question?
Doctor, I just have a question, if I may.
Yes.
So for the posterior shoulder dislocation,
Yes.
does it always give the light bulb appearance?
Yeah, but I'm
Like
not gonna ask this on exam. This is resident level.
Okay.
You just
Thank
need to know. So guys, the people asking about LGDs, how will be asked? I just explained it to you guys, okay? I went every LGD and they told you what kind of questions or what kind of things you need to focus on. More than this, I'm going to send you the MCQs. If you attended the lecture and paid attention and attended this review session, you'll be able to understand what I'm going to ask you.
Okay, thank you.
Okay, anything else, guys?
Thank you so much, doctor.
Okay, so the last thing is you guys, the leaders of both groups, you can ask me in the WhatsApp group, but don't send me question every 2 minutes, okay? Either you collectively discuss it with all the group and see the comments